Hello, everyone. This is Karen O'Hara, Director of Marketing and Communications with WorkCare. Welcome back to the 5th week in our series of webinars on preventing and managing COVID-19 in the workplace. We really appreciate your participation, and to anyone who's joining us for the first time, welcome. This session is being recorded and will be available on our YouTube channel within about 24 hours. During the presentation, you are on mute, but you can submit questions at any time using the Q&A function on the Zoom application. At the conclusion of Dr. Harris's presentation, he'll take some questions, and questions that we don't have time to cover we'll respond to in writing and distribute after the webinar. We've been doing that every week. We get a lot of questions. They're very much appreciated. We typically average about 30 to 40 questions a week. So if you look at those previous weeks' documents, which are on our website, you'll find a lot of really helpful information there and see how questions have progressed over time. It's interesting. I'd like to introduce our speaker now. Many of you are already familiar with him, having joined us in past weeks. Anthony Harris, M.D., M.B.A., M.P.H. Dr. Harris is a board-certified occupational medicine physician. He is WorkCare's Vice President for Onsite Clinical Operations and an Associate Medical Director. Dr. Harris is our lead clinician for our COVID-19 response. We really appreciate him taking the time out of his busy schedule to offer this weekly webinar and keep us up to date on everything related to protecting employee health. Now I'll turn it over to Dr. Harris.
Excellent. Thank you, Karen, and thanks to everyone for joining. Welcome back and/or welcome for the first time. We'll jump right into the presentation for today. We want to make sure we have time to get through everything. The format unchanged. If it ain't broken, don't try to fix it, right? And so far, it's been working well for us to go through the clinical updates, talk about a little bit of the pathological and microbiological processes. We'll update on the epidemiology, the growth of the virus and disease around the world and U.S. We'll talk a bit briefly about prevention, but really focus in on today workforce strategies that are going to be germane to testing. So we'll get in more detail around testing and then return to work as it pertains to testing the workforce. Very hot topics for today, obviously. So let's go into the clinical presentation. We haven't seen much change in terms of the clinical presentation over the last 2 weeks or so. We've updated on GI symptom prevalence, headache, loss of sense of taste and smell, the anomia, hypopnea. And these still are prevalent, right? But one of the things we want to point out is that we're using best practices we're seeing across the clinical continuum in the US and beyond to make sure we're catching these type of presentations. If you look at the CDC and their symptom checker, if you would, risk stratifier, you can go on and take it for free, as you have been able to for the last several weeks, but it doesn't address some of the more up-to-date presentations. Whereas if you look at what we're doing with our daily screening and what a lot of employers, including Johns Hopkins in their self-checker, symptom checker, is also screening for is the more recent loss of sense of taste and smell, particularly diarrhea as well. So we just have to be mindful in how we regard the clinical presentation of today's COVID-19 in the workforce and beyond, that we're checking for these type of instances. So when we talk about so when we talk about the presentation related to the continuum of infection, symptomatology, and stage 3 disease, we mentioned this briefly last week, and we'll talk about this more specifically as it pertains to testing, right? Where that stage 1 proliferation of the virus causes a immunosuppression. And we're able to see that more prominently as we test here. So when we talk about the testing in particular, as we get into the pathology of the disease, we brought up a number of tests that are available in the ex-US market, and some are becoming more available in the US market. And we'll talk about how these are conducted from a clinical standpoint, but also what the FDA has said about some of these tests. They range from, doing a rapid test, pinprick, and they can range to the swabs that you're seeing in terms of the PCR, looking for genetic material of the virus from a swab from the nose or from the back of the throat. And FDA has granted clearance for a number of tests to be conducted, but primarily in the laboratory. Okay, and that's what I want to focus in on in terms of emphasizing that these type of point of care tests, POC, point of care tests that can be done at the work site, and by clinicians, obviously. They're available broadly ex-US, but only one has been approved, and we'll look at that in more detail. But how do these typically work when we talk about these rapid tests? These tests impart a methodology that's similar to a pregnancy test, right? Where you need a drop of blood from the person being tested, and that drop of blood kind of cascades up a film, if you would. And on that film, there's antigen, meaning that the actual components that your immune system reacts to are imprinted on that particular test, right? And your blood and immune components will pick up that antigen attached to it, and then as it progresses further up the testing strip, attaches to some attached antibodies. And those antibodies then again form in conjunction with your antibodies, whether they're present or not in your blood. If they are, they'll form with those antibodies, and the test is able to be positive in that regard, right? And there's a control line there where we want to see that control line positive in every test that's valid, right? That's just a fail-safe to ensure that whatever test that instance of the test has been conducted well in regards to the reagent, et cetera. So just like a pregnancy test, you would see a couple lines to denote a positive test, a positive result, meaning that you do have immune components, whether it's IgG or IgM. These tests can identify both. A negative test means that that double line is positive. The negative test is just that control line, and the control line not being present means that that test may not be valid. You need to repeat a test, okay? So that's the basis for how these tests work, right? And again, it's looking at two immune components called IgG and IgM. IgM shows up first within about 7 days after a person is exposed or contracts COVID-19, and IgG shows up later, right? And so we can see from these tests a number of things that we'll talk about in a second here. One of the things to note, though, that's important as we compare the testing to that phase, that first phase where there's immunosuppressing, meaning that the virus is actually causing a decrease in the number of immune cells that an individual may have, is that there's a fair number of people, sometimes up to 8 to 10%, 6 to 8 to 10%, that actually won't mount an observable immune response, meaning that I may have been exposed to COVID-19, I may have gotten sick and recovered from COVID-19, but I don't show any immune response when I have one of these tests conducted on me. So it's a point that we know exists in regards to immunologic testing in general. There's a number of people that will never mount a observable immune response to, let's say, a tetanus shot. And seeing a tetanus response is a fair number of people, again, same population percentage, that will never show a response. Yet and still, this type of testing is going to increase in its utilization in the US, as it has ex-US, and it has a place in the return to work algorithm that we'll talk about briefly here. But we want to real quick go over what the significance of these tests are in regards to what an IgG and an IgM positive lets us know, okay? So if you are being swabbed, and the first column here is the swab and looking for genetic material of the virus itself, and we test, we assume that we're going to test for all three. That's becoming more prevalent now, that a laboratory is going to test for all three, IgG, IgM, and the rapid PCR, real-time PCR, which is the RT-PCR here. We're able to see then if you only have a positive PCR, you may be infectious, right? And in that window, and you haven't mounted yet or haven't observed a mounted immune response. If you're PCR positive and IgM positive, you're still in that early stage of infection, whereas if you have both IgG and IgM and PCR, you're still infectious, but you're probably later in the disease process. And then late in the disease process, we can still see genetic components of the virus in your system from a swab. And we can also see the later stage of immune response with the IgG. So that's a IgM negative, and the PCR and the IgG is positive. And as we continue down, a person who's IgM positive and IgG negative still may be in the infectious window, right? Having fully mounted a total immune response, excuse me. And someone who's IgG positive can have had the disease previously and they've recovered. So an IgM negative and IgG positive, and you've already cleared all the genetic material, the virus, from your system, we can see that picture with this type of approach. And then again, if both are positive, still may mean you're in that early infection stage, or you have recovered and you're still having that IgM linger around, right? So I went through those briefly, but I want to make sure that you understand these are considerations important in the return to work process, and they will be more prevalent as we move forward with regard to their utilization in the US. I'll leave the next slide here just for a brief moment, just to let you know, FDA has approved one test like this and one test only. That's from the company Cellex, right? And it lets you know that, again, testing, we're still behind in terms of being able to ubiquitously test people on a routine basis. However, we're moving in the right direction. So let's get into the epidemiology updates week to week of the global picture. Cases per million continues to, this was April 1st, continues to become more bleak, right? April 2nd, 7th, and now as of the 13th of this week, we see darkening of the globe with regard to prevalence of COVID-19 per million. If we look at new confirmed cases on a daily basis, again, we're seeing a similar picture, a darkening of density of disease on the global scale. When we look at then specific total cases, we're still leading the way, and most likely no one is going to catch up to us anytime soon until our curve starts to flatten. We'll talk a little bit more about that briefly. But again, if we look at April 7th compared to as of the 15th, we were just under 400,000 cases. We're well over 500,000 cases now in the US alone, right? If we look at total confirmed deaths, we a week ago were behind Spain and Italy, and unfortunately now, as you all have probably learned, we are #1 in terms of total confirmed deaths as well as a result of COVID-19. If we look at then testing on a multinational level, US still total number of testing conducted, we're #1, right? So obviously that's very favorable for us in terms of being able to articulate the level of burden of disease. in the U.S. If we look at from week to week where we are, we're still number one. We continue to be, and that is not likely to change. But if we look at then again testing per 1,000 of people in the country, we're still not number one. We've been number three on the 7th, and we're still number three if you look at it today, well, as of the 14th, right? And so we still have some ground to make up. Like I said, we're heading in the right direction for increasing our per capita or per 1,000 people testing, but we need more yet and still to catch up to our counterparts across the pond. Total number of daily confirmed deaths. This was a metric that we looked at for the first time last week, and the rolling 3-day average was poignant to a dip that we saw at during last week's presentation, right? And we were going to pay close attention to that dip to see if that continued. Did it? Yeah, it did, until recently, where we had an uptick in terms of that rolling 3-day average. So what does that mean? That means that we're not there yet in terms of truly bending that curve in regards to both prevalence as well as, or incidence, as well as confirmed deaths. So we'll continue to watch that so that we can anticipate how we're doing in terms of the proverbial peak that you hear about of disease in the U.S. So let's talk about briefly prevention, right? We know that social distancing is something that's been studied. This was the Stanford study that I've presented now twice. We won't go into more detail on this particular study other than to show the projection of social distancing, right? So now let's see what research is showing us in regards to the actual historic picture of social distancing. And this data is published, one in the Lancet and the other in the journal Science. And both studies looked at Hunan, the province in China, right? And we know that that was the epicenter of this outbreak. And they looked specifically at the model of social distancing and its effectiveness. And at what point they tried to project at what point should China end its social distancing to protect from a recrudescence of disease in that region. Okay, and so when we talk about what happened at Wuhan, we know that 11 million people were sequestered, and the travel in and out of Wuhan was prevented on January 23rd, right? And these studies both pointed to the success of social distancing up to 92%, right? In terms of decreasing the infectious spread of COVID-19. And so that vast impact, 92%, up to 92%, was what gave confidence, obviously, to the activities that you see now with regard to social distancing in the U.S. and abroad and globally. But if we look at, the latest of what happened as of last week, you learned most likely on the 8th that China in Wuhan ended their social lockdown. Right. It began again on 23rd of January. It ended on April 3rd. So now let's try to do some loose prognostication here in regards to what does that mean for our window of opportunity to end social distancing. One of the curves that will help us look at that is the daily confirmed cases of COVID-19. So this is comparing the US to China. This is looking at the trail of confirmed cases, starting at the point at which each country reached the 30 days of confirmed cases, right? 30 cases. The day that they reached 30 cases confirmed in that country is the beginning of each of these curves, okay? So we both are kind of towards the left started, and we progress down the curve with increasing number of days since that day, that initial day where we had 30 confirmed cases. And if we look at China, in particular now, if we look at China on the dates of January 23rd to the time they ended their social distancing on April 8th, right? And we look at the nature of their curve, they began to flatten their curve. Here, I'm gonna see if I can get my little handy laser pointer here. So they began to flatten their curve at approximately 20 days after the day they had 30 cases confirmed, right? So it took them, in short, they took them 20 days to flatten their curve. Now let's compare that to the US, right? Where are we right now? At 20 days out, we're still rising, right? 20 days from our 30th confirmation of disease, right? And we're still climbing here. So we still have some room to go, right? Our curve is projecting out further, hasn't flattened yet necessarily, and it's been obviously more than 30 days since the beginning, and the beginning here being that 30th confirmed case. So another way to look at this is looking at then our doubling time, right? And this is comparing many countries and the number of days that they double disease, meaning the number of cases doubles every so many days. You know, at its quickest, Sudan, 2 days. And if we zoom into where the US is, we're right at 7 days now, doubling the number of confirmed deaths. So not cases, excuse me, deaths, every 7 days, okay? So we'll keep track of this method or this metric, excuse me, week by week to get a good estimate of what's our trajectory, what continues to be our trajectory. Let's go back to the curve then, lengthening now from the January 22nd all the way to today, which gives us a little bit more perspective on, are we flattening or are we not, right? And we are. I would say we're starting to, if you look at this curve just at face value, we're starting to flatten the number of total confirmed cases in the US. And we're right at about, we're approaching 40 days from that initial 30 days, 30th confirmed case in the US, right? And again, China has flattened at 20 days, and it took them all the way out 60 days later after flattening to end their social distancing, right? In comparison, we're 40 days out. So even optimistically, if we estimate within 60 days from now, we'll be at a point that will flatten will end social distancing. Again, that's very optimistic because we're about 20 days even beyond that, that of China. That gives you a perspective of how long we're going to be social distancing, well into mid-June, probably 20 at a minimum 20 days after that, right? Well into July. So again, it gives us a really good perspective in comparison to our counterparts in China that had success early on in flattening their curve. So what do we do about it, right? How do we position ourselves as businesses and to help protect our workers? What techniques can we use, right? So we learned 2,500 years ago from everybody's probably heard of the art of war, right? And what we learned is that, in short, the best defense is a good offense, right? Attack is the secret of defense. Defense is planning of an attack. And that was the literal quote. But we know that in the workplace, if we're able to get in front of how we do screening and we do that well, that's going to help us in that offensive attack on decreasing the prevalence, not just in our workplace, but in our communities, right? And so what are the key components to that solid offense? It's screening. Right, you got to be doing screening at this point. If you're not just behind the curve, right? You're at risk in terms of not being able to limit disease in the workplace. So screening, doing IR thermography is now becoming ubiquitous across the U.S. It's already been done, obviously, ex-U.S. as of 3 months ago. It began back in January, and now we're seeing more and more adoption of it in the U.S. And in fact, we'll talk about how CDC is even recommending temperature screening in certain cases. So that's the first piece of it, right? IR thermography is necessary, but it's not sufficient. So the daily screen is something that is now becoming a staple in how we architect our prevention in the workplace, meaning that workers are taking a screening on a daily basis before they leave work or when they show up, and we're capturing what their current state is in regards to fever, in regards to a number of other clinical presentations. Actually, let's go ahead and, in the interest of time, hop to that. And we're able to see then, again, not only are we going to screen for fever with IR thermography, we're going to screen for cough, shortness of breath, GI symptoms. All the symptoms we have been presenting here on a week-to-week basis has to be a part of your daily screen now, right? If it's anything less, you're going to miss an opportunity to protect the workforce in regards to an individual presenting with one of these symptoms that could be indicative of COVID-19, right? And in fact, again, if we look at what CDC recommends, even for workers who have been exposed, they're again being pretty prescriptive on doing pre-screening because of that close contact. What is close contact? Close contact is defined as within 6 feet of somebody who's had confirmed COVID-19, right? If we put a temporal relationship to that, we use the guidance of 10 minutes, right? And that's coming from the literature that studied out of Wuhan, several hundred cases of community versus household contact, and that 10 minutes was the threshold for increased disease or transmission. So we use that. We also take the guidance of doing that pre-screen. Again, measuring temperature is what CDC is suggesting, doing regular monitoring. So we have a process by which we're able to then detect if somebody changes in their presentation. Meaning that if I have a cough that develops into a fever, that develops into some shortness of breath, we're tracking that for individuals as we go forward. Again, when it comes to wearing a mask, hands down, the answer is wear a mask. If you're outside of the house, you wear a mask. If you're in the workplace, wear a mask. There's no way to get around wearing a mask at this point in time in terms of best practice and recommendation. Why? Because asymptomatic individuals, which we know can be upwards of 50% of people with COVID, are walking around and they're able to transmit disease, but again, they don't have any symptoms. So wearing a mask helps protect us all. Social distancing obviously is there along with disinfection. But again, CDC has now become in a position of being more aggressive than they have been with regard to doing these type of controls in the forefront. So in terms of return to work protocols, there's a number of scenarios, and I promise you we've seen a number of employers try to encapsulate all these different scenarios, and the HR departments are trying, along with EHS, to not only articulate what these scenarios might be, right? My employee is positive for COVID, they were exposed to somebody with positive COVID, or let's say they're exposed in the community or household member to COVID. What do I do, right? If they're low risk, they still have symptoms, but low risk for COVID, what do I do in that case, right? These are all individuals who may need time away from work, most likely, to understand their absolute risk, and if they are in fact going to develop COVID in that time period, we monitor that. But then again, for the return of work, what do we do about it, right? And the first response that CDC has said is turn to your occ health clinicians, right? And this is not a pubbing oneself in regards to our place in this continuum, but it's to suggest that there are many clinical protocols, clinical scenarios rather, that need to be taken into account in order to understand on an individual basis what someone's true risk is, right? And so I presented this last week in terms of looking at the exposure disease, the infectiousness, and any overriding orders or policies from a corporate standpoint that are in place. But I want to revisit this because it's important to talk about how we make these case-by-case determinations, right? So first and foremost, we strongly suggest you don't take this on yourself as employers, right? It's just a burden that becomes complicated by not just, trying to articulate the questions to the employee and to the workforce, but also when we talk about PHI, this can quickly get into a situation where those questions are gendering responses that are protected health information. So having these done by a clinician, whether it's your OCDOC or a local physician that is well versed in COVID responsiveness, then that's the route that's going to be the easiest for our employers and for even our clinicians. The guidance that CDC is recommending is the beginning of the consideration for return to work. There are these other aspects that we have to consider moving forward. And so how does testing play a role in that? Testing is going to be more and more utilized to help a clinician in determining whether or not an individual is immune to COVID-19, has been exposed and recovered from COVID-19. And as we see it move forward with regard to point of care testing, we're going to be able then to test more and more individuals in that return to work paradigm, right? Each clinician will likely have their own algorithm to help you determine when it's appropriate to test and not to test. Some employers we know are requiring testing of 100% of the workforce in order to come back to work. Do we believe that's the best practice? We haven't seen that play out yet as a best practice of a testing 100% of the workforce. And obviously in today's testing environment, there are considerations of availability that are still barriers to performing that type of approach. Yet and still, it's moving that direction where we're going to be testing more and more individuals to set a diagnostic criteria such that we can ensure this person has been exposed, is immune, and will likely never have to worry about COVID-19 again. They're safe to go back to the workforce. But then there's again, deviations from that when we talk about which tests may be available at that particular time. So do know that we're going to spend more time in the coming week here talking about which tests have been approved in the next week by FDA. The thing to point out is that the testing that's available in a laboratory is different from what's able to be done at the point of care. Most of the tests you're hearing about right now fall under the FDA's emergency utilization, EUA, what I have here, emergency use authorization, right? And a laboratory that's been CLIA waived, we won't get into the regulatory piece of it, but FDA said you as a laboratory can conduct testing that we have authorized, but may not be necessarily FDA cleared. Right. And so that's what we're relying on right now. That's why those testing numbers have climbed the way they have. But this is a new wave of testing we're considering when we talk about point of care testing and the return to work process. So with that, I'll pause. I'll ask questions and we can get into any nitty gritty that we need to with the time that we have remaining. Thank you so much.
Thank you, Dr. Harris. This is Karen again. As usual, we've gotten quite a few questions. And I will just jump into the ones that came first through chat and then through the question and answer forum. As we plan for the reopening of the office, what protocols should we put in place for screening employees and sanitizing our office workspace?
Absolutely. So the screening process has to start with the IR thermography, temperature monitoring, and the daily screen. If those aren't in place in that return to work, even before you consider return to work, then we know you're gonna miss an opportunity to keep people safe, and we're actually seeing it happen. So that is the first layer of the strong offense, if you would. And then in terms of the return to work clearance, involving your either local clinician, involving your occupational health specialist is going to be key, because each person will have an individualized presentation, and the determination of return to work is still not, let's say, linear enough for a complete algorithmic approach, right? And so that's why you have to have still that clinical judgment as a part of the return to work process to help prevent, again, the individual who may still be infectious 18 days, 20 days out from their initial disease, because they're an outlier from what we typically would see in that 12-day window of somebody recovering. So because of that, that involvement of the clinical specialist is necessary. and should be a part of your return to work process.
Okay, thank you. Do we have any information on how long the virus can survive on clothing? Any guidance for field employees working in the utility industry who may have to enter customer homes regarding proper donning and doffing of work clothes would be helpful. I would think this would apply not just to utility, but to many types of employees. For example, I just had a locksmith come over, and he was wearing a mask, but he didn't have on any other protective gear, and he came in the house.
Indeed, indeed. So we know that based upon the study conducted by NIH, looking at the persistence of the virus on different materials, that it can survive for a couple hours on cloth material, right? And we know that as the material changes from cardboard, which is up to about 3 hours, we know that it can survive longer on metal and on stainless steel, and plastics like polypropylene up to 3 days. So on the fabrics side, we also know that just washing your clothes does clean the material and prevent spread and transmission of the virus. So donning and doffing best practices is something that we can, Karen, perhaps send them as we have those protocols for our healthcare workers on the front line, but also know that best practice includes taking off, if you're in an infectious environment, right, around people that you know has confirmed COVID, then you need to be taking off your clothes as soon as you enter, or even sometimes, in the mudroom per se, before you enter back into your home, and launder those clothes either right away or put them in a plastic bag or something that sequesters them until you're able to launder them. And those have been the best practices that we've seen across the board.
Okay, that's really helpful. This is a question about transmission through the oral fecal route. Do you have any guidance on using public restrooms and creating awareness of toilet plume and avoiding hand dryers?
Absolutely. So there was a study conducted about a month ago now, looking at virus spread from hand dryers. And we actually, I believe that was the content from our very first webinar several weeks ago. The recommendation is to steer away from hand dryers. They are not sufficient to, while they work well for bacteria in terms of decreasing spread of bacterial contaminants from the hand after washing, it's found that the virus, because they're substantially smaller in terms of microns than bacteria, can be pushed into the air by hand dryers. So paper towels are preferred means of drying the hands in that scenario. Where the fecal oral route is not fecal oral in this case, right? It's fecal respiratory. And so we know that the virus is shed in high numbers, in a high count in the feces. Those individuals that present, up to 48% of people are presenting with diarrhea. And we know the virus load is very high in diarrhea. So yes, that there is concern for fecal transmission of the virus. So washing your hands obviously is key. In terms of aerosolization of the virus from bathrooms, that I'm not aware of any studies that have looked at that particular exposure. And as of right now, there are no special guidance other than good hand hygiene. And obviously, if you're asymptomatic, we want you to wear a mask no matter what, right, when you're in public.
Okay, I just want to remind everyone that, especially those who haven't joined us before, that we try to keep these sessions to about 40 minutes. And so any questions we can't get to, we summarize in writing and distribute after. So we'll just take 2 more, and then in the interest of time, we'll be concluding today's session and distributing the questions tomorrow. The next 2 questions are both related to testing. The first one is, how can a non-essential business get into the pipeline for rapid diagnostic testing kits?
Well, that's a problem even for the essential businesses. It's a problem for healthcare organizations even. Again, there's only one approved point of care kit, Celex product, which is the manufacturer by FDA. So outside of that, you have to be a laboratory, which is specific to CLIA-waived laboratories, meaning you've been practicing most likely as a laboratory. You have the appropriate licensure through CLIA, and which is a federal designation, and you're able to then conduct testing on site if it's under that waiver, that CLIA waiver. There are organizations that are such as ours that are now offering testing, and we make it available through our clinicians. Excuse me, and other clinical outfits are doing the same. We know that there are several that are trying to identify nationwide a means to provide point of care testing through their CLIA-waived laboratory in kind of a truck, right? They said that they bring a truck that's a mobile laboratory, and they're able to then conduct testing for your organization at your site. And we'll see more of that. We've seen an increase in the number of those type of operations, and we're going to continue to see an increase most likely because of the lack of point of care testing otherwise with these more available kits that have been in ex-US use to significant number. I mean, there's probably over 15 different approved ex-US tests that require just a drop of blood from a finger. But again, only one approved in the US.
Another opportunity for entrepreneurs. This question, the next question that we'll conclude with, really you partially just answered, but just for clarification, the questioner wants to know what's the difference between the accuracy of a rapid blood test versus a rapid nasal swab test? And then they also ask about what nasal swab tests have been FDA approved.
Sure. So the nasal swab tests are all looking for genetic material. They're called real-time PCR. So they're trying to identify, is the virus present in the swab itself, from the nares, the nose, or the mouth, right? There's a new saliva test John Hopkins is launching even this week. It's still under evaluation, but still. So they're all looking for the same type of genetic material. The accuracy of that, and we talk about the number of false negatives, excuse me. So it hovers around 30%, and that's been pretty consistent across the board, ex-US or even in the US. So 30% of people with COVID-19 will have a negative test with that approach. If we look at the point of care tests and the WHO published variability in those tests, the sensitivity, meaning their ability to actually detect whether or not you have an immune response to an exposure from COVID-19, ranges from 35%, around 35% to 86% sensitivity. So that's a huge range, and that's part of the reason why we haven't seen a lot of those tests approved by the FDA, because of that huge swing in its efficacy to actually detect those components from your immune system, IgG and IgM. So that gives you a good idea in comparison of accuracy in terms of sensitivity, or effectiveness in terms of sensitivity of both of those approaches.
Okay, thank you, Dr. Harris, and thank you to everyone for joining us today. We'll look forward to having you back next week at the same time, same place. And please watch your inboxes for the videotape version, or the recorded version, excuse me, and the questions and answers tomorrow afternoon. I hope everyone will be safe and take good care of yourselves. Thank you.
Thanks, everyone. Stay safe. See you next week.